He's on the board
many years ago, and
every
that's
day.
deceased since.
I haven't seen him in a while.
And he drives a
I mean,
bus.
they're all good.
I know him.
And Dr. Pullen, he was like, I was afraid
Cause I
this was
fly
our
to,
good
well,
way. And I
sometimes
said,
when we're out of gas
yeah.
in North Vernon, I
So,
take my plane and fly
over
to
there.
he
over
sat
Allen
there,
Green.
he was like,
Well,
here's
yeah,
this constitution.
they have a car there, you
Don't
drive
go for
around with a courtesy car.
Once we get it in the fucking, in the green, we're good.
And when he came in, looked at me and he was like,
So you're gonna teach
oh,
us
God, he's
today.
got cancer. He's got,
Just same old
something.
BKGs,
And I kept thinking, well,
kinda
maybe it's
semi-mimics.
CHF, but he doesn't sound junky.
The tumors
He
are
would move
shrinking.
from here to
There's
John,
11 of
and
them
he'd be
in
going,
the liver, and they're spread out enough they don't think.
That's the other.
something's going on somewhere.
I know that.
No, stop connecting. Time for their stupidness.
Number 10.
That's nice. That's why we won't get more animals, because
I've got a 22-year-old granddaughter.
my daughter is pregnant. It was a hard road getting there, but
I've got 7
she's
grandchildren,
doing.
but, you know, Sadie's serious, she had a serious boyfriend and everything, and she's a junior in college, and I'm thinking, she gets married, I could be a great grandfather by the
with Mr. Tabby that's live. This is Julie Bailey, for those of you who do not know her, but I think most of the people in here know Julie. She's from the cath lab, but I was able to do a lot of my paramedic clinicals with Julie in the ER back in the day. So unfortunately, the cardiologist she had coming kind of bailed on her, but not only just today, but yesterday and tomorrow.
Yeah.
So I wanted to say one thing before she gets started. We had a little bit of an issue with the Lifeline guy that was supposed to be here next week. He could not find anybody to come in. He asked to come in on June the 18th, which extends it out that week after the 11th, which was supposed to be our last, and Daryl approved that. So we will not be here next week, okay? It will be through, after that it'll be through June 18th, and I'll put out another schedule so Daryl can send it out, so everybody will have one, hopefully. Any questions on that? If not, we're gonna let Julie take the floor.
All right. Well, I know I've come and given the same spiel to you guys before, but I don't know if anybody doesn't have these cards or needs a card. Let me know. You can have them. I've changed it up a little bit. Hi. I'm not going to do like the basic. You guys know the basics, the anatomy and everything. I'm just going to go over a bunch of the STEMI mimics. And so with the Everbridge, we get that verification. So I know in the beginning people were used to just transmitting the EKGs and they knew it wasn't a STEMI, but they always transmitted the EKGs. But I want you to know that when you transmit that EKG, it only goes to the IC. The interventional cardiologist is the only one and me, the ER triage, and the NAC are the only ones that get that EKG. That is your asking permission to activate the cath lab. So it's not just sending an EKG to the ED doc for them to look at it and see if he agrees that it's a STEMI. So if there is a question, if you don't think it's a STEMI, or if the machine says it's a STEMI, you don't think it is, that's not the time to send that to transmit it. You can I say this without repercussions of somebody on, are we on YouTube or something? Okay. That's the only way you can send it when you transmit it. Make sure and send it to the ER triage. They can always let the ED take a look at it. But if you don't think it's a STEMI, bring them into the ER. They'll repeat an EKG, do a little bit more evaluation, and then they'll transmit it to the IC. So I want to give you the confidence to know those STEMI mimics, the bundles, the LVHs. I want you to be confident that when you're transmitting, that it's going to the IC, and they're going to look at it, and then if they agree that it is a STEMI, they're going to activate the cath lab.
What should we do if we have an incident where for some reason our monitor won't transmit? Well, I've done that too and sent it to whoever I call.
Yes.
And they, well, I can't, activate them.
So that's an ER issue, and they are supposed to.
How am I supposed to activate it when I don't even have a phone number?
Right, you don't. So you can take a picture and send it to that triage phone, and they can always give it to the ED doc. Or if you think it's a STEMI, say, I have a STEMI. ER is supposed to go ahead and activate us. And they will. I don't know in your situation if they did, but they're supposed to. But we still get a fair amount of false activations, and we're going to go through some of those. So I like the idea of the transmitting. If it can work, that's the best case scenario, because we can weed out some of those false activations.
Well, it seems like the two times I've had problems, each time the monitor said acute MI. It didn't say STEMI. It said acute MI, and it had some borderline things in there, but.
Did you feel like it met?
Yeah, because there was like slight elevation and there were reciprocal changes.
Okay.
So I had concerns, and I did take pictures and send it to the ER phone, and they kept telling me, you need to call them and activate. I said, well, I ain't got.
You don't activate. That is you. I mean.
Well, yeah, it's kind of like, but I mean.
So in those situations, let me know if that happens, if they are saying that they're not going to activate, or just give me those concerns and I'll investigate and see what happened and talk to them again about it. Okay. I did want to tell you that Dr. Boschby was going to be with me today, and he's a great guy. He's a great doctor. I have not personally heard him. Well, I have heard him present other things. He's a fast talker, and I'm not sure he's the best presenter. So I think he's nervous about coming, but I assured him that I would like him to come and just sit. We'll go through some of this. I will present, and then you guys can ask those questions, bounce some questions off of him. So he is more willing to do that, and he suggested the 28th that he would be available. And I don't know if that's something that we could, we used to do huddles in the Bay. I don't know if you guys still do that. No, but maybe we can set up something less formal. I don't know. We'll get it. But it has nothing to do with him not. He is very involved, wants to be involved, and he's good about teaching or after the case. If for whatever reason you're still there, you probably won't still be there that long. But definitely, if you bring a STEMI in, he would like you to stay as long as you can. I know you're restricted, but hopefully we can get that vessel open in 10 minutes. You can at least watch that. So if you have questions, they're very open to. All three of our docs right now are open to discussions. So if you want to ask something, I can't answer it, we'll get that doc involved and answer your questions. Okay. So a couple of those slides that I have left in here because I just want everybody to know, I've had some pushback before on my personal goal of patient to EKG of 5 minutes. Please know that I am eyes wide open. I know the struggles you have getting from the call to the scene to the patient. There's a lot that go in between there, and I know that there's a lot of barriers. But from the time you get to the patient, I think it's reasonable to go as fast as we can and get that EKG within a goal of 5 minutes. If it's easily obtainable, it's not a goal. So just as fast as you can, and keep this in the back of your mind that with every 15 minutes of delay, which the patient has already delayed 2 hours or more days, but I don't want that to be on me. I don't want that to be on you guys. And I think we are very good. Our patient to EKG times are very consistently around that 5 minute time, so I have no concerns there. But to me, I've done this for a long time, and what has helped me in my ECG interpretation is this algorithm. And I do it methodically every time so that I try not to miss anything. But the very first one, if you have ST elevation in 1 to 2 millimeters and 2 sister leads. And we all know what the STs, some of these slides are left in there from the paramedic students or EMS students. But these little cards, for the guys that just walked in, I have these cards, and on the back I have this algorithm to help out. The color-coded, they have to be in 2 of the same color to qualify for that ECG, to be a STEMI. And they match up with our coronary arteries. RCA is a C. RCA is a C, and our LAD is up and down. LAD is up and down, and our left circumflex kind of goes across and then down. Our left circumflex goes across and then down. So of all the ECGs that might come up and say STEMI, acute MI, in the EMS interpretation, the ZOL, only that orange or red part is actually a STEMI. All the rest of them are some of them that we can't identify that we would identify once we get to the ER. Mostly LVH or bundles. Those are it's probably 50-50 with the LVH and bundle. We've gotten a lot of bundles here lately of false activations. Yes, there is elevation, but if you go down this algorithm that we're going to go down, you're going to weed out those mimics. So when you look at your EKG and you immediately see this elevation, 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 but when you go through the algorithm, you're going to be able to weed out those LVH and bundles. This is the one that's the most confusing to people, is the LVH, and it's on the back of this card. And you're going to, I know it's hard, but to count those boxes, but if you have these deep R wave and Q waves, you're going to add one of these, whichever's tallest, and of 1 and 2, V2 is the longest. It starts down here. And then 5 and 6, whichever is the tallest, and I think it's this one. So one of these and one of these. Add them together. If it's over 35, it's LVH. And with this deep, deep depression, it automatically drags up the STs. And same with bundles. If you have these deep, deep, it's dragging them up automatically. Do you guys still learn about scarbosa? So LVH and bundles, they can still have MIs. They will have this underline, but you're not just talking a 1 to 2 millimeter elevation, it's 5. So unless you have these tombstones, or there's a couple other criterias, but that's when it's indicated of a STEMI. But if you just have these deep deeps and elevations, it is not going to qualify as a STEMI. Does that make sense? And the same, and with your QRSs, I was going to say you don't have calibers in the back, but your QRSs are already calculated in your interpretation from your Zols. So if it's above 120, it's too wide. Too wide, you can't count it as a STEMI. Make sense? Huh?
That's interesting.
Yeah. And we get a lot of those because they all show this ST elevation. That's their new normal. Bundles and paste and LVH, if they have that condition, that ST elevation is their new normal. So you'll see this, 5 millimeters. It's very obvious. So the icing on the cake, you might have elevation in 2 leads, you might have short QRS, you might have narrow QRS, but do you have the reciprocal changes? So go back to the, sorry. Sister leads are all in one color, and you have a right sister, and then everything from here on over is on the left side of the heart. So if you have elevation on the right, you should have depression somewhere on the left. If you have elevation on the left, you should have depression on the right. It's on the opposite side. That's your reciprocal changes. And that gives you the confidence to call it a STEMI. I have minimal, you were talking about minimal elevation, and you said you have reciprocal changes. That's a higher alert that yes, you have something going on. Obviously, ST elevation on the right side, and we have the depression on the left. That just increases your specificity. When you first look at this, it's not totally impressive, but you break it down. I don't know how you guys learned how to interpret your EKGs, however you do it, whether it's just starting here and going across, or if you do the Sally or the ICL leads. I particularly like the ICL leads. Starting with the inferior eye, and I don't see elevation. Elevation, yes, a little bit, just a little bit. Yes, in the lateral leads. So yes for elevation in 2 leads. Are they too tall? No. Are they too wide? No. And then do we have reciprocal changes? So we have this minimal elevation in the lateral leads, but there's your predictive reciprocal. same, pretty squatty, but you see this little bit of an elevation here in this inferior. If I have inferior elevation, I should have depression somewhere on the left side, and I have it right here. Inferior STEMI. Making sense? Okay, so this is the nuts and bolts of it. And the ones that I've used, these are all actual studies. We'll go methodically through it, the first couple, and then we'll just kind of go quicker so I don't waste up too much of your time. So if you have you have to have number 1 before you go on to number 2. So you guys all call out. Do you see elevation in any of these leads? No. So it's just normal. There you go. Do you see any elevation? This is your test. Yes. So inferior, yes. Plus, if you don't stop there, you got to look at all of them because you got this too. So yes to number 1. Are they too tall? It's 5. It's okay. Not even 10 here, not even 10. So no. I mean, yes, I'm sorry. Not too tall, yes to less than 35. Are they less than 0.12? It's hard with these that are so wide with the elevation, but you're looking at any other, they're all skinny. So if I have elevation in the inferior, do I have depression in the left side?
Yes.
Yes. It will be an inferior with reciprocal changes in V2. And it was an inferior. Have you guys all been able to?
Those are ones you've done?
Yeah. Yep. These are the old way I used to record them. Okay. Oop. What did I do? Okay. Elevation. You guys are already ahead of me, I know. But yes, we have elevation. Is it too tall? 5, 10, 15, 20, 25. I can't even see where it ends, but yes. So that is LVH. And I'm sure we've all been burned by this before.
I don't know that I have ever been taught the LVH, the long part of it. It's, I would ask and people would say, don't worry about it.
Yeah, well, it does matter.
Well, I would think that it would, but
Yeah.
A lot of times you're actually going to see that a lot in healthy runners too.
Oh, that's a good point.
And they'll actually have ST elevation throughout, and they won't show any depression, but they'll have ST elevation everywhere, but they'll have the PT waves.
Yep, that's a good point. And there again, you have the algorithm. If you didn't have the reciprocal changes, can you call it a STEMI? I would call in and say, I have this ST elevation in all leads, but I don't see reciprocal changes. That might be one of them that they would want to just see a picture first before they activate the team. And I mean, it's not the end of the world to activate, or it's absolutely not the end of the world to transmit it for the IC to verify it. That's the best case scenario, like I said. It's the times when you can't transmit, and those are the ones that are the iffy ones that you can't transmit, which you're depending on the ER to activate, which that gets a little more gray, because I'd much rather the IC take a look at it and say yay or nay than activate the whole team, because that gets complicated.
Sometimes whenever we call in, if we can't, like Art said, you know, if it will not transmit for whatever reason, we've had a couple of people say, well, we'll see you whenever you get in here and we'll determine.
So is that when you say, I'm not sure if it is or not, or is that you saying, I think it is, and they won't activate? Now that's a problem that you need to talk to me about. If you think it is and they're not activating, I need to know that, because we need to talk about that. When you say, I'm not sure if it is, and they say, we'll just reevaluate, now that's acceptable, because that's a first EKG that's not totally diagnostic.
Right.
And then your door to balloon time becomes a subsequent EKG if they should redo, because things change within minutes. I mean, it could be very normal, and then you'll see later on, I've got a couple scenarios where it changes. So if you're not sure, it's okay to come in and get it reevaluated. And then if for some reason they say, I see on your EKG that it was a STEMI, you should have, then we'll talk about that. But it's all right, you know? Okay. So elevation, yeah?
Yeah.
Height, 5'10". So is it less than 35? Yes. Width, those are wide. So those are too wide. It's a bundle. Okay. Elevation? Yes. Height? 5, 10, 15, 20, 25. So yes, within 35. Width? Less than? Yep. I have elevation in the inferior. Do I have depression on the left side?
Yes.
Yes. It's an inferior STEMI. Again, you know, through all this that I've been doing this since '91, and they say that the most of your STEMIs come from the left side. I disagree. That's always same spot. It seems like it gets clogged up right there.
So you're saying it's more that you have more on the right side?
I've witnessed it more on the right side. Yeah. But they're the experts, so. Elevation? Where is the elevation?
1 ABL, D2, D3.
Anterior, lateral. Yes. Height? Less than 35?
Yes.
Yes. Width?
Narrow.
Narrow. Elevation on the left, do I have depression on the right?
Yep.
Yes. And this was a really nasty STEMI. Left main completely plugged up, nothing. Got a little pacemaker that we put in, a balloon pump, that's a balloon pump. The patient made it, but it was yucky, pucker.
So you put a pacemaker in this person.
Yep.
But you didn't have to open it up
Temporary pacemaker
Okay.
from
So
the
this
venous,
person was
femoral venous.
one for like a cabbage or something? Or
No.
open heart?
So we don't typically stent the left main, but in a STEMI where there's nothing, they're gonna die. So we do. We opened it up, we put 2 wires down, and then put a stent right there.
Okay.
And that got him, that might have been all I mean, we have stented the left main, but we don't like to.
Right.
But I think that was enough for them. And then we took the temporary pacemaker out like the next day, balloon pump came out the next day, and I think they did okay, but I'm not guaranteeing that. They survived my time and got them off to the next person. That's all that counts. Okay, do we have elevation? Where's the elevation? Yeah, yes. Height? 5, 10, 15, 20, 25. Width? Yes. And you said elevation in anterior? Do we have depression? Let me say this about that, because I always used to say, because that is not included in your color-coded EKG. AVR is by itself, so I used to say it's not a sister, it's a cousin, nobody cares about it. We do care about it. When there is elevation in AVR, it's kind of indicative of a left main disease. I found that, but that's not a STEMI. So we might bring them to the cath lab urgently, but that's not I'm calling a STEMI, get the cath team in. That's a more of a evaluate and then decide if they're going to take them or not.
Some of us were taught that AVR is just a throwaway lead.
It is not. I used to thought that. I used to think that. But I've seen enough left mains now that they have that elevation in AVR. And I pay attention more to it. But it is not something to call a STEMI team for. Okay, so I do not see reciprocal changes. And that is just benign early repole, normal for them. This proves my point of I know you guys have to keep, but you have to push the button on the Zoll to get a 12 lead, correct? Make sure you don't just take the one, and I know you do several. There's never been a time when I'm like, why didn't they do more? But just keep that in the back of your mind. You see the first one and you know that you can take your time and do all the things that you need to do before you come in, but know that any change in the patient or periodically, what's your protocol? How often do you do one?
We're just required to take one.
Oh, okay. Well,
It's
I always see more. I've always seen more than one. I don't think I've ever just seen one, but
It just depends on,
I mean, if they're having chest pain, you're going to keep repeating EKGs, I would think.
I mean, I look up.
You should.
Yeah, and I look up the monitor to see if there's any changes,
limited
but
amount of 12 leads we can do.
it just depends on, I think, the tech and the patient themselves.
So the ACC tells us in the hospital that if the patient is still having chest pain, you should repeat an EKG every 5 minutes. So if your travel is more than 5 minutes and they're continuing to have pain, I would suggest repeating every 5 minutes. Because this is a patient that came in, now this was 30 minutes later, but the difference in these two is frightening.
Dr. Schneider said yesterday in A&R that he will sometimes repeat it 4 different times.
Absolutely.
You know, just
Absolutely. I can attest to that because he'll send them all to me. And he's like, and he does that because he's like, the EKG looks good, but the patient does not. So he's going to keep on taking them, until finally he gets something that's going to get somebody's attention. And then the opposite too. If you have a nasty looking EKG and the patient looks fine, you're treating your patient, not your EKG. So just.
Well, that's kind of like the doc in the box. I don't even like to look at it at first. I like to look
Correct.
at the EKG. And then when we sat in on the Zoll training, the guy that was here said that like 95% of it's right, but you've got to look at that other 5%.
Right.
But some people will look at that and they'll call a STEMI, and I'm standing there going, I don't see it.
Absolutely.
So.
I can't tell you how many times I've had that. I'll look, as soon as I get it on my phone, I'll look at it and I'm like, what are they thinking? And then I'll look up at the interpretation and I'm like, that's what they're thinking. Don't go by that because it just makes you look bad, because and a lot of times it's artifact and it will call a STEMI. And it's like, you can call in and say, hey, my machine might be saying STEMI, but I don't see it. Don't transmit that. Just bring it in until you see something that you know that's a STEMI. So if you guys are not familiar with this, this is the kind of feedback that I give back with hopefully every STEMI that you bring in. This was a 57-year-old, I don't think this came in by EMS, came in with subtle EKG changes, but they did take him to the cath lab because I don't think he was looking great. And then again, I told you it was always in this right. Had a nasty clot right there. You can see it's a clot right there. With TIMI 0 flow, TIMI 0, 1, 2, and 3. 3 is the best. And after stent, DES, a drug-eluted stent, he got excellent results. And frequently, when this happens, in the right a lot, as soon as we reestablish flow, you get the ectopy, and then they go into VFib. So it was a 57-year-old, went into VFib arrest. Actually, it was before we even ballooned it at this time. But that's when I see it most, is after you open it up, then they'll fibrillate. But also happens as soon as we put them on the cath table. like the last 3 that we've done, that's when it is. So when you're taking your electrodes off, and we haven't gotten ours quite on yet, don't do that, because that's exactly when they're going to code, is when you're trying to put them on the table. But this one was able to be treated right away and went home and had a great life for 2 days later.
So you prefer us keep our
Yes.
on with the monitor on the floor while you guys get situated?
Yes. And if anybody tries to take yours off, tell them that I said no. Because I'm telling you, that's exactly when it happens. When you're ripping all your stuff up and they're trying to get oximeters on and oxygen on first. But I mean, it's a timing thing. I like to have our Zols on first. If you have a Zol, you have regular Zol, the pads. You don't have the radio opaque pads, do you? So we have special Zol pads. So we might have to take your Zol pads off if they're in the same spots as we do. We do anterior, posterior, but we have the radio opaque so we can actually see through them. And it does make a difference. I've tried it. You can't see the cardiac vessel if you've got a pad on. That defeats the purpose. Okay, this was not as subtle. This obviously is not that guy's EKG. This is the next person's EKG. So again, you see the ST elevation, tombstones. Do they not teach tombstones anymore? I was teaching paramedic students and they're like, what's a tombstone?
I haven't taught paramedic class or cardiology for a while, so I don't know.
Yeah, well, that's it.
Morgan in here? Do they teach that in your class?
No. That's bad. You don't like that, obviously. Okay, so ST elevation, yes. Height, less than, yes.
Yes.
Width, yes. Reciprocal changes. If we have elevation in the right, do we have depression in the left? Yes. Again, right there, right there. And this was a 48-year-old. How's that make you feel?
Do you see that they're getting younger?
Yes, they're getting younger. It's
And
disgusting.
Why do you think so? Is it just lifestyle? or-
Yes.
exercise.
Lifestyle, stress, yeah. A lot of smokers. We're
whenever I
getting
came
more
in-
and more meth.
Well, when I came in, it was like the 60s children that, that was the PCP and all of the other stuff that their part was. But now it's like, Grayson and I were talking the other day, and, you're seeing a lot of 50-year-olds.
Yeah, 50s, 40s,
Bad.
and they're dropping.
Yeah.
They're not just coming in with chest pain, they're dropping because they haven't had time over the 70-year-olds that have time to build up their collaterals. These younger ones just throw clots. COVID, I think. I've not heard that officially, but I've seen a lot of clotty since COVID.
Everybody that's been vaccinated. It's what we see at the funeral.
Yeah, right? Yeah. Seeing,
I think the shots did some stuff too. so-
And they say that's why I had the pulmonary embolism.
is that right?
Shot.
Yeah, that's unfortunate. I've not made that connection, obviously, but just a lot more clots lately.
Have you noticed an uptick since COVID?
The clots, yes.
Everything
Yeah.
we eat's poison.
What's that?
Everything today that we eat's poison.
Yeah,
True.
yeah.
Yeah, just look at the label.
Yeah. So 14 minutes, and I think that was Dr. Boschpai. I was going to leave his name in on that one, but all our guys now, have you guys met all 3 of our interventionalists?
That's why I was so excited.
I know. So Boschpai's our most seasoned, but he's still a kid. And he'll curse you upside one down. Not mean, but he's a character. But I think we've got a good group right now. So
Who's the newest one?
Patel.
Patel.
He's the youngest one, I think. They're all young, but yeah. Enazat is very quiet, but I've been very comfortable in their rooms. Over the years, some are good, some are not, but I've been happy with the ones we have lately. But I have noticed, I will let you know, that if you feel like the cath team is not being activated right away, like when you call in the ED, they might be getting pushback because Enizat likes to hear a story first. He doesn't like just to activate the team without getting the story. He must have gotten PTSD from something, because every time I say, just activate them, you can cancel them if you want. They're saying it's a STEMI, it's a STEMI. He wants to know the story. He wants to know, he goes, I need to make sure it's not a 90-year-old with a hemoglobin of 4 or an aneurysm. That's the scenario he always gives me. So I think he's had probably a death in the cath lab with somebody that probably shouldn't have gone to the cath lab. Might have been having a STEMI, yes, but probably shouldn't have gone to the cath lab, because there are STEMIs that shouldn't go sometimes. Yeah, does that make sense? He likes to hear the story. So yes, he thinks it's a STEMI, but he wants to know age, history, vitals. And once he gets that, then he'll activate. All right, elevation? Yes. Oh. Height? Yes. Width? Hard to see, but yes, because of that elevation, it's hard to see. And reciprocal changes. If I have it in the left side, do I have depression on the right side? Yes. So here we go with the left. And this was an EMS, 50-year-old, called with substantial chest pressure, shortness of breath. EKG showed ST elevation. ED went to the ED for just a short, 49 minutes. That's not that short of time waiting for the STEMI team. Well, that's EKG to cath lab arrival. TIMI 3 flow after a DES. It was there. Sometimes it's hard when you get in there. Everybody's coronaries look different. So sometimes, what's the difference between that cutoff and that cutoff? It's hard to see. That's why it's so important that we see the EKG and not just go in blindly, because we know where to kind of focus our attentions on. This little thing turned into that big thing.
Oh, wow.
So this whole area was not being fed. So I know sometimes people will come in and say, I can't transmit an EKG, but they want to see, only because they want to know what to prepare for. We have different catheters. We need to change in a mindset of where we're going to go. Okay. Do we see ST elevation? Yes. Is it too tall? 5, 10? No. It's not too tall. Is it too wide? CRH says 129. It says a STEMI, but it's a bundle. And it's not 5 boxes. Right?
Can't be over 120, right?
Huh?
Can't be over 120.
Right. 120 is, or above, indicates a bundle. Can the bundle still have a STEMI? Yes, but you're going to have that really big. So I would see, if you are, and look at your patient, if they're tanking, say, hey, I see a bundle, my thing says STEMI. If you can transmit, you can transmit, but know that he might say no, it's not a STEMI, and you're not saying, why aren't they calling? But these are the ones that get people all the time, these bundles. Got it?
You got me.
Yeah.
Yeah, I mean,
Everybody's gotten it.
It's just like this, the patient wasn't doing real well. He's older, probably called a STEMI, and turned out to be a left bundle branch, and they activated, and we figured out, we got into the cath lab. Doc's like, wait a minute, it took a while. You guys were great. I mean, they did say, hey, it's fine, call us.
Yeah.
Nobody degraded us.
Right, and they shouldn't. They shouldn't, because these are tricky, especially in your back of the rig and the patient's looking like a STEMI. So I just want to get lots of these scenarios out so that you can think about it, and you might call in saying, hey, it looks like a bundle. This might be something that we need to look and reevaluate. You have any questions on that? We're going to keep going through a bunch of them. Elevation, yes. Height, low. Width, wide. It's a bundle. It even says bundle. I mean, the last one was tricky because it said STEMI, and your patient probably looks like crap. This one, your patient might look like crap, but it says bundle.
But I also see some rabbit ears.
Yeah.
In some of those as well.
Yep.
Yeah.
Oh, do we teach rabbit ears?
I don't know. I was taught rabbit ears.
Yeah.
Any questions on that one? I mean, these are all ones that we have been activated on, but the doc said no, they weren't. So, but the key is to call with your report too. I mean, not that they would ever accept a patient from you guys and leave them in a room for 20 minutes without anybody coming in. But if you're alert, if you feel like there's something going on, they need to be meeting you in the room. I'm sure they always do.
So, question on.
Not the cath lab, but the ER.
Ones like this that are the bundle branch block, do they usually go upstairs? Are they watched? Are they placed on medication?
All of, I mean, it depends on everything else that's going on. They will automatically get an EKG, they'll probably get a chest x-ray, and absolutely troponins, find out if there's anything else going on. If their troponins are bumped, they'll be admitted, and we'll probably do them the next day or if they're bumped. But if they're negative troponins, and they get 2 sets an hour apart, 2 sets of troponins, and they might, I don't know, do GI cocktail or whatever else they do, and their chest pain's gone and relieved, and I mean, they're gonna have this rhythm forever.
Yeah.
And if they rule them out, then they can go home.
It would be nice if some of these that have been diagnosed that if when we get out in the field because they have chest pain that we knew something like this, but
I tried to push that about 20 years ago, that people carry their most recent EKG with them. And it was a money thing. Nobody wanted to invest. I wanted them to have a little laminated card with their most recent EKG. I thought that would be smart, but
even if it was on, like, you know, people hand us like their stuff from the doctor or the hospital with their meds and their allergies, and you know, even as a diagnosis of bundle branch block or something.
I'll give you a perfect scenario. There's a lady out here in town that has chronic ST elevation.
Really?
Yes. And she's been brought in about 3 times for her STEMI, and it is not a STEMI. At his, what?
She got
Did
me.
she?
I had
Yeah.
one. Yeah.
Yep.
Doctor said that's normal for her.
Yep. And it's nothing that you can, you can't,
So does she
you-
call in for like chest pain?
Yeah.
yeah.
So it's just.
Chest pain, do the whole thing like, hey, I got a STEMI, and they're like, no, you don't.
No, you don't. But because they know her, and that's the glory of being able for you guys to call in and give us some more information, because if you're out far enough, we can go in and find out who they are, what their past history is. And they might have just had a STEMI 3 days ago, and they still have their elevation, but we can say, you know, they'll come look at them, but they probably won't take them right to the cath lab, depending. You know, that's a very big if, because if they were supposed to go home with their P2Y12s and they're not taking them, they probably are having a STEMI.
So I believe it was you that I talked to not real long ago, but somebody had been cathed, and after they got home, they started having chest pain, and I brought them in, and it looked like they were having a STEMI, but you said that can be, or somebody told me that's going to be indicative of the stent process? Or
So there's a couple things that happens. Forgive me. So if you, let's see. Okay, say this blockage was up here, and you have to put a stent from here to here, this vessel might become jailed. So, but you are risking this small vessel for the benefit of this. So you don't want to work you want to work on the main highway, not the side road, okay? That is just one of those unfortunate things that we might have to jail. Hey, how are you? Jail a vessel. And that will cause a STEMI because sometimes they come back. The brackets of the stents have little holes in them, and sometimes that just might clot off for a little bit, but then reestablish flow. Sometimes you don't ever get that back, unfortunately, but that's a jailed vessel. So that area that was feeding in there will die. That's better than this dying, right?
Right.
This will cause ST elevation. They might go home with ST elevation because of that process. So maybe that's what that was.
Whoever.
But how you can't diagnose that.
No. But I can't remember if it was you or it might have been one of the ER docs somebody was telling me, well, they just gotten a stent like 2 days prior, and I said yes, and they said, well, it can be. And that's what had happened.
It can take a long time. Another scenario would be if you open this area up and it was sludge and you pushed it all the way down to here, this down here might not completely open up, so now you have another STEMI down here.
Okay.
But you've opened this area up, so they might still continue to have elevation for 3-4 days.
Yeah, it was something similar to that it was just, I was like, do what? I've never known that in the past,
So not always do we go in, put a stent, and their STs, the majority of the time their STs come right down and they recover. But occasionally they have issues ongoing, but it's being monitored. The other thing, in your situation, if you brought them back and they had ST elevation, they would check the patient, check their troponins. If they're going up, that's a problem. If they're coming down, it's leftover, residual from the previous event. Leftover. So if they're coming down, so they'll take their if they're stable enough and they don't feel like it's emergent, they need to go in, they'll do their 2 troponins, and if it's coming down, then they kind of chill them out for a little bit. Any other questions on that? I think this is another one. This is one that I was talking about. Do you see ST elevation? I don't see any ST elevation. I see a T wave, but there's your line right there, right on that line. That's your baseline. I see this, and I think it was artifact, but I really think that this was one of those that said that, so they transmitted it. Because I think the report was, I don't think this is a STEMI, but the machine said it was, so I'm going to send it on. And I would discourage that. If you think it is, and it doesn't say it is, then transmit it. But if that says it is and you don't think so, trust yourself. Because, I mean, I don't know if you're worried about, does this have any legal action? If that's, yeah, so it's not like, well, the machine said it was and you didn't call it. But there is obviously no ST elevation there. But I would keep repeating them over and over and over, especially if they're having pain, to make sure that I'm not missing something. Elevation?
Yep.
Yes. Height? Looks good. That's 1 and 2 or 5 and 6, so those are short. Width? Narrow. If I have elevation here, do I have depression? Yes. And again, same picture. I swear to God, these are all different people. Another 58-year-old. Ah, it sounds like the same. Hopefully I didn't put the same slide in here. No, I think the other one coded. This one didn't code. But 58, that's disgusting. And I will say, we have to eat better. But I was on call this weekend and got called in for 8 times. And I went to White Castle 3 times. That's my comfort food, and it's terrible. I felt guilty about it, but by the last time,
You
now,
felt so guilty you had to go 3 times.
yes. I will say though, when I went to get 2 breakfast sandwiches, and I think those are better than McDonald's. They're a real egg, and it's a little, those are good. It wasn't the burgers. One time it was, but by the last time I went there, I was like, the guy's like, "Are you having a good day?" Like, no, I'm not. Shut up. And one more thing I have to say, I have a Subaru, and it's nice and it talks to me, but when I get in after a particularly terrible weekend and it says, "Good morning, Gary," my husband, I'm like, whatever.
I'm not Gary.
It was rough, obviously. All right. Am I over time?
No.
Okay.
Dr. Schneider's supposed to be here sometime after 10, so you're good.
Okay. Do you see elevation? No, I do not either. And this was at 043 or 0443. And the ED, when they arrived, do you see elevation?
Yep.
Yes. So I have elevation. Is it too tall or is it short, I should say? Is it short?
Short.
Yes. Is it wide? It is. It kind of looks a little bit, but it's not. And if I have elevation in the inferior, do I have depression in the left side? Yes. This is absolutely a STEMI, and it's the same person as this. How much longer? 30 minutes later. This is that scenario that they brought him in, and the EMS didn't think it was a STEMI, but the ED's like, well, this is a STEMI. It has nothing to do. It was not a miscatch or anything. It was not a miss. It was just patients change.
Timing is everything.
Timing is everything. That's right. And this was that patient, 65 years old, was called 911 for chest discomfort. ECG did not meet STEMI criteria. Upon arrival, they repeated the EKG, which they always should be ready to repeat that EKG as soon as they get to the door.
Right in the room with us.
Good. If they're not, that's something we need to address. But the repeat EKG showed inferior ST elevation, so the team was activated, and he, again, had a right 99%. So this could be plaque rupture, spasm, smokers with their little tiny vessels. Normally, they smoke, they get constricted, they might have elevation, and then it's no elevation. Elevation, no meth, no meth. No. So that's another thing about if you see elevation and you keep taking an EKG and now you don't see elevation, that happens too. That's from coronary spasms. But if you called us during that elevation, that's fine. But know that if it goes away within 20 minutes, it might not meet STEMI criteria. They might not take them to the cath lab. Depends on how the patient's doing. After 2 drug-eluted stents, they reduce that blockage. So in cases like this, the door balloon starts with the first diagnostic EKG. It's not from the first medical contact, which it normally is. So it's actually a very good time. That's my favorite. I don't have a tattoo, but if I did, that's what it would be. All right. Any questions, comments, scenarios that you've had that somebody was mean? Everybody gets angry in the middle of the night, but we're all doing the best we can with what we have.
I think it's changed a lot for the positive over the years.
and things like that. If I'd known that Dr. Bash probably been able to talk to you, I'd heart blocks and all the different ACLS rhythms and things like that. But before we get into like the nitty-gritty of all the arrhythmias and ACLS rhythms and whatnot, I just want to overview a little bit of how disruptions in the electrical system causes different types of heart blocks. So before we get into that though, I just want to talk a little bit about EKG preparation. You guys do a very good job, but I just want to kind of review it for everyone. A good high quality EKG sometimes does involve some hair removal if the patient is like diaphoretic. Sometimes we have to use like a little bit of glue to keep the pads on the patient's chest, so skin preparation. Yeah, sometimes we just get bad stickers because they're old and they won't stick anymore, so age of electrodes. And then probably most importantly is the electrode placement. And one of the important things that sometimes I'll see is, you know, with the limb leads, it doesn't matter if you choose the wrists or you choose the shoulders, but it's just got to be the same on both sides. You can't have like a right wrist and a left shoulder, or you can't have like a wrist that's here and then the patient's like with the wrist up here. Like that's not going to work. It's got to be in the same plane with the limb leads. Same thing with the ankles. You can't have one kind of up higher on the thigh and one down low near the ankle. It's got to be in the same plane. I like wrists and ankles myself, but it's not wrong to do like shoulders and I guess thighs, but I don't know, it's just my bias. And then as far as the you know, chest placement, the V1 and V2, kind of fourth intercostal space, that's right about, with men, right about the nipple line is where that V1, V4, just on either side of the sternum. And then V4 goes into that fifth intercostal space, and then V3 is kind of in between the two. And then, you know, once you're in that fifth intercostal space, you just kind of work your way on around for V5 and V6. So that's ideal placement of the EKG leads. Just a quick little anatomy. So this is more like the coronary artery anatomy, but it's good to understand that because when we do get these acute MIs and we see arrhythmias, it's basically because of cut off blood flow to parts of the electrical system of the heart, especially with your right coronary artery. I mean, everyone's anatomy is a little bit different, but for example, the SA node is innervated by the right coronary artery about 60% of people, and the AV node in about 80% of people. Those are the two big pacemakers of the heart. And but everyone's anatomy is a little bit differently. Sometimes it's the left-sided coronary system that innervates the SA, AV node and whatnot, but the vast majority is the right-sided RCA. Hey Grayson. Don't worry about all the verbiage on the right-hand side of the slide. The thing I wanted to kind of focus on was the picture. So that's the one that was kind of at the beginning of the presentation. So the SA node is the pacemaker of the heart. It's when the heart's electrical system is working correctly, that is what paces your heart, that's what starts the signal, that starts the whole process of your heart beating. And it'll send a signal to your AV node, and as that signal travels through the atrium, that's the top part of the heart, the atrium, as it travels through the atrium, it causes the top part of the heart to contract, and it pushes all that blood in the top part of the heart down into the two ventricles. And then as that signal reaches the AV node, there's a pause, and that's on purpose. That pause is to allow the atrium time to fill your ventricles with blood. And then after that pause has gone through its course, that signal goes through what's called the His bundle, and then it goes through your left and right bundle branches, and then the Purkinje fibers. The ventricles have now filled with blood, contraction occurs, and all that blood pumps to either your pulmonary arteries, to the lungs to get oxygen, or to all of your organs. So when we talk about arrhythmias and different types of blocks, it involves just pathology errors within this electrical pathway that have occurred. And I was going to go over the anatomy of like everything on the EKG, but I think the most confusing to me was always the QRS. Like what exactly is the Q, what's the R, what's the S? So the Q wave within the QRS complex is that first downward deflection of the QRS. And not every QRS on an EKG will have a Q wave, but it is technically the very first downward deflection. And then once you get back up to the baseline, which is like that PR segment, that's the end of the Q wave. The R wave is anything above baseline within the QRS. Within the QRS. So the R wave begins, like, I wish I had a pointer. Does this thing work? Yeah, here we go. Nope. Sporadically.
Is it turned on?
Is this thing a pointer?
See, that's the one you used of mine. It comes out the bottom. And then it should be turned on.
Oh, do I plug this in my computer?
Yep.
Oh, I don't have that kind of drive. That's all right.
You don't have one?
No, not that kind of drive.
Sorry.
That's all right. So anyway, do you know what I mean by the baseline? Like anything, that first straight line and that last straight line would be called the baseline on the EKG. Anything above that would be your R wave within the QRS complex. And then the S wave is when you start getting below the baseline. That negative deflection would be your S wave. And that is basically the electrical signal going through your ventricles is what the QRS complex is. It's sending the electrical signal, getting it ready to contract. J point is probably the most important part to me because that's the very beginning of the ST segment. And once you identify the J point, you can identify if there's ST elevation or depression and whatnot. It's the very end of the QRS complex is the J point. Yeah, so here we got a normal ST segment with the J point at the end of the QRS complex, and then on the right would be very concerning for myocardial infarction, ST elevation once you identify the J point. Oh, thank you. This one, very bottom? Okay. Yeah, so J point right about here, J point right about here. This would be your baseline here. This would be your baseline here. So steps from the EKG. Now the nice thing is the computer does a lot of this stuff for us already, but lead 2, the reason why it says to measure the PR interval in lead 2, and that's the distance from the beginning of the P wave to the beginning of the QRS complex, is lead 2 is your best lead to actually tell what kind of rhythm you're in. If you're going to see P waves, lead 2 is your best bet to see the P waves. So if you're struggling to tell, man, is this a sinus rhythm and what kind of rhythm am I in? Lead 2, that's where my eyes, that's the first lead I honestly look at is lead 2 to tell me, do I have P waves? Is this a sinus rhythm? It's the easiest lead. On most EKGs, when it gives you the rhythm strip on the bottom of the EKG, I can't remember, do you guys do that? Does your EKG give you a rhythm strip at the very bottom? I don't remember if it does or not.
I'm not gonna lie, I'm like 30 seconds behind you, so
No, you're all right, yeah. So I think
it comes at the end.
Okay, yeah. So on our EKGs, the big printouts, it gives us, all the different leads, and at the very bottom, it gives us a rhythm strip, and it's lead 2 that it gives us that long kind of rhythm strip on the bottom of the EKG. And the reason is because that's used to tell you what kind of rhythm you're in. It's the best place to look for a P wave. Measuring the QRS interval, anything above 0.12 milliseconds, or 3 of those tiny boxes would be abnormal. Anything below, around that 0.1 milliseconds is normal. You can use the R to R interval to help calculate your heart rate. We'll talk about that. You can tell regular or irregular. Again, I use lead 2 to help me with that. Finding the J point to look for ST elevation. Obviously, examine the ST segment. Assessing the T wave, it should be upright. If it's inverted or what we call biphasic, where it kind of goes down below baseline then up below baseline, that could be concerning for ischemia or infarction. And if there is ST elevation, checking for reciprocal change, ST depression, T wave inversion, and other leads. So these are all those intervals, and again, the EKG machine's very good about calculating the vast majority of this stuff for you guys, but I still think it's good to know exactly what it's talking about when it's calculating it. So for example, the PR interval, very beginning of the P waves, at the very beginning of the QRS complex, when you think about like a first degree heart block, that's what it's talking about. This is your atrium having that electrical signal kind of go through that top part of the heart. And when you see a first-degree heart block, that's because there's a delay in that signal going from that SA node to your AV node. It's not a dangerous finding, but that's what they're talking about, is this PR interval being prolonged. There's your QRS complex. Again, the first downward deflection below baseline is your Q. Everything above the baseline, again, this would be your baseline, this could be your baseline. Anything above the baseline is your R wave. Everything below the baseline is your S wave. There's your J point, the very end of the QRS complex, and the very beginning of the ST segment. So there's your ST. This is normal, it's right at the baseline. If it was way up here, we'd be worried about ischemia or infarction, I mean. And then obviously this is the beginning of your T wave. Sometimes you get a little bit of a U wave. And we're back to our baseline segment. So just lots of different intervals, and I like to use the R to R interval to help me calculate the heart rate, but the machine, again, automatically does that for you. The formula I like to use is every 300 divided by every big box. So if this R wave started here, we'd have 1, 2, 3, 4, I don't know, like 4.5 big boxes. So 300 divided by 4.5, whatever that comes out to, would be roughly the heart rate of this person. And then QT interval is important in my world, or in our world, because if you have a really prolonged QT from either drugs or like antidepressants, antipsychotics are very common causes of it. Certain types of nausea medicine, Zofran, for example, can a little bit prolong your QT interval. You can develop a torsades. That's one way that you develop. If your QT interval gets too long, that's one way you can develop torsades. Really low magnesium is another way that can happen. Give you torsades. All right, I've got a neat YouTube video that let me see if I can get this loaded up for you. That does a lot better job than I did. Once we get through the commercial.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
All right, so I think this is a pretty good job. And again, I think that's important to know is exactly what's going on with the heart electrical system, because it helps me to better understand the different types of heart blocks anyway. So let me get out of here and try to figure out how to get back to my presentation. Slideshow. Current slide. Yeah, good, okay. Any questions about that video or so far? Okay. All right, here we go. So the different types of heart blocks. We're going to talk about first degree, Mobitz 1, Mobitz 2, third degree, left bundle, right bundle. So again, we think about that video we just saw. You know, what do you think causes a left bundle branch block? When you get through that bundle of His and it divides into the left and right bundle, if there's something disrupting the electrical flow through that left bundle, that's what's giving your left bundle branch block. Same thing with the right bundle branch. You get something that disrupts that propagation of electrical signal through that right bundle branch, you're going to get a right bundle branch block on your EKG. Just kind of helps me visualize it. So here's where everything goes correctly. So the EKG up there, it's a normal sinus rhythm. Again, lead 2 is your best place to look for P waves. Like I was talking about earlier, on the EKGs we get in the emergency department, at the very bottom is always a rhythm strip, and it's always lead 2. And the reason is it's your best lead to look for P waves. So if you're having trouble finding them, look lead 2. That's your best place. You know, as far as the way the quadrants of the heart are broken down, your lateral leads are lead 1, AVL, V5, V6. Your inferior leads are 2, 3, and AVF. And then your anterior leads are V1 through V4. That kind of breaks down the different quadrants of the heart. Again, the computer does basically all this stuff for us, but you know, measuring the PR interval should be less than 0.2 milliseconds. QRS should be less than 3 little boxes, or 0.12 milliseconds, or 0.1, yeah. And then P wave before every QRS, obviously. What's the rate? Is it regular or irregular? Evaluate the ST segments. I looked this up. So does anybody? It surprised me. I wasn't thinking it was going to be that many. I think it was 2.5 billion times. Something like that, yeah. All right, so first degree heart block. The nice thing about first degree heart block is it's not dangerous, but it's basically where this PR interval becomes prolonged. Anything above basically one big box, anything beyond one big box of a PR interval would be considered a first degree heart block. Again, it's nothing that's going to make a cardiologist upset or make them feel like, oh, we gotta do something for this patient. Not a dangerous rhythm, but still, a lot of times you'll see on the EKG readouts like, oh, this patient has first degree heart block. That's what they're talking about. They're talking about this PR interval being a little bit prolonged. That signal from the SA node to the AV node, for whatever reason, that signal is getting delayed. Just a little bit, it's getting delayed. It's still getting there. It's still causing propagation through the ventricles. Everything's still functioning normally. There's just a little bit of a delay from up here to down here, and that's the first degree heart block. So in patients who are very bradycardic with a first degree heart block, atropine should still work. There are certain types of heart block where atropine is unlikely to work. This is not one of them. Atropine should still work with a first degree heart block. All right. So first of all, anybody want to guess what kind of rhythm this is? So let's look for P waves. Let's look down here in lead 2 since we have a rhythm strip. So that'd be our P wave, right? And then this would be our PR interval. We'll start here. P wave, PR interval, P wave, P wave. So to me, it looks like your PR interval is getting just a little bit longer. Is that You guys agree with that? I mean, I think it's getting a little bit longer, and then we got a P wave and no beat. So PR, PR, PR. Yeah, it's a winky Bach. Mobitz 1 winky Bach. So again, this just illustrates why I think lead 2 is the best place. Now, this person actually had a pretty good ability to see P waves and other leads as well, but lead 2 is your best one. Yeah, so winky Bach. So progressively lengthening of the PR interval until a drop beat. And a drop beat basically means there's a P wave, but there's no QRS that follows it. So the signal originated from the SA node, it made it through the atria, and then by the time it got to the AV node for whatever reason was not ready to accept it, and then the beat was lost, and it did not happen. It's not usually a dangerous rhythm. It tells me you got a diseased electrical system, but it's not typically a dangerous rhythm. Again, atropine should work in this kind of instance if you have like a symptomatic bradycardia. Not pacemaker, not necessary. It's just one of those things. I kind of group it in with the first degree heart block. It's kind of neat to identify, and you look at the EKG, you're like, whoa, what's going on? Why is there a big blank between these QRS complexes? And then you kind of look at it a little bit more closely and like, oh, this person's got winky Bach block. All right, so same thing, lead 2, I like to look at that to kind of tell me what kind of rhythm I'm in. So P wave, right? PR interval looks to be pretty constant. And then we get this P wave and a drop beat. And then we got picked up again. PR interval looks to be the same roughly. And a drop beat and another drop beat. PR interval is about the same as what it was before. What type of heart block would this be? Yeah, well, type 1's the winky Bach. Type 2, Mobitz 2 second degree. This one's dangerous. This one's a pretty severely diseased conduction system to give you a Mobitz 2 second degree block. This can progress to like a complete heart block, a 3rd degree. So randomly drop beats, P wave with no QRS. There's a good chance atropine will not help much if you're like severely symptomatic bradycardia. I still try it when I see this, and if I need to increase the heart rate, I'll still try atropine, but a lot of times it won't work. So we'll use either transcutaneous pacing or another medication called isoproterenol to try to increase the heart rate. What's that?
Isoprel's a little bit squirrely.
Yeah. So yeah, these patients need a pacemaker. Ever I show this kind of an EKG to a cardiologist, they say, yep, I'll put a pacemaker in them tomorrow. Or if they're really symptomatic, they'll do it that night. So a patient that has syncope that you see this, that makes me very nervous because there's a decent chance they're going in and out of 3rd degree heart block. Speaking of which, so we've got P waves, right? Your PR interval is different every time. You got P waves with no QRS. There's no consistency. It's not like it's gradually lengthening and then dropping. And the P waves are fairly, that one's buried in here, but fairly regular when they're happening. So you've basically got a top part of the heart where the SA node sends the signal and the bottom part of the heart to ventricle that are both doing their own thing. They're not communicating at all. So that SA node is sending signals and the AV node's not receiving them. The AV node's kind of like the backup pacemaker for the heart. So if it's not receiving a signal from the SA node, it will start to send its own signal at a much slower rate, but it'll start to send its own signal. The bundle of His can also do the same thing. It can give you like a ventricular escape. It can kind of be its own pacemaker, but just much slower rate. So this is a complete heart block where you've got P waves that and no communication with the QRS. So basically the top part of the heart electrical system is not communicating with the bottom part of the heart's electrical system. Very dangerous stuff. Usually very low blood pressure with these folks. A lot of times they pass out with it. These people absolutely need a pacemaker. Yeah, it's like we were talking about. So the P waves are fairly regular, no communication, there's no rhyme or reason with the QRS complexes. You get a junctional or ventricular escape. Again, the AV node can be a pacemaker, these bundle of His can be a pacemaker, even your ventricle itself can be a pacemaker. It's just at a much, much slower rate. Atropine likely won't work. I've actually never seen atropine work with 3rd degree heart block. But transcutaneous pacing, again, a medication called isoproterenol. Sometimes our cardiologists want us to use that instead. These folks usually go to and get their pacemaker fairly quickly, especially if they're symptomatic. They'll usually take them within hours of me calling. All right, what do you think? Is this a STEMI?
No.
Okay. Are we seeing ST elevation? Yeah. So why is it not a STEMI?
Too wide.
Yeah, so in V1 and V2, we've got this QRS complex that's wider than 0.12 milliseconds, or 3 little boxes. I know it's kind of hard to see, but if you were to really zoom in there, I promise you, it'd be wider than 3 little boxes, or 0.12 milliseconds. You've got the same kind of idea with a positive S wave in leads 1 and AVL. This is a left bundle branch block, and it's by far the most mistaken electrical finding with a STEMI, because it's got ST elevation, and there's actually a whole lot of conditions that can give you ST elevation that are not STEMIs, but this is the one that gets most commonly confused for STEMI. Again, when we had that video we were talking about, this is where there's disruption in this left bundle branch. Something is delaying the signal going through this bundle branch and propagating through the Purkinje fibers. That's what gives you this appearance on the EKG. So a wide QRS with negative S wave in lead V1 and V2, and then a positive S wave in lead 1 and AVL. Now, it used to be, if this was new in the setting of chest pain, that was one of those indications to go to the cath lab. That has since been changed. That's no longer the case. I still call the interventional cardiologist and say, hey, I've got a patient with chest pain with a newly diagnosed left bundle branch block. They don't get too excited about it anymore, but I still let them know about it. And then if their cardiac workup, like troponin, starts getting really high, then I call them back. And sometimes
Is this something that the cardiologist or the patients will be told to maybe have it checked on?
I always tell them. So I always tell them, hey, looks like you've got a left bundle branch block. Have you ever been told that before? And most of them have. Most of them, oh yeah, I've heard that before. And then I've got the benefit, I can pull up their computer and pull up an EKG. I'm like, oh yeah, it's been there before. They've had this in the past. You guys don't have that benefit, but a lot of folks do know. They go, oh yeah, I've been told that before. So I think the cardiologists are telling them. I know I always do when I see it. Again, same thing as with like a first-degree heart block or a Winky block. Although the conduction system is diseased, it's not an indication for a pacemaker. Not overtly dangerous. It's just unfortunately very often mistaken for a STEMI. So here be an example of an actual STEMI. So you've got a narrow QRS, you've got ST elevation in like V2, V3, V4, V5. You have reciprocal change with ST depression in 3 and AVF. You got a little bit of elevation in 1 and AVL as well. So this would be an anterolateral STEMI, probably an LAD lesion. And then this would be an example again of that left bundle branch block, not a STEMI at all. And you can see how they can easily get confused. They look a lot alike. I mean, they really do. I get it. I get why they get confused, but yeah, it all has to do with, that width of that QRS and the fact that this one doesn't have it, this one does. Now, is it possible to have a left bundle branch block and a STEMI? Well, of course it is. I mean, of course you can have a STEMI and have a left bundle branch block. We'll talk about that here in a second. So yeah, you've got ST elevation here, but there's got to be a point where it's like, that's too much. Like, you should not have that much ST elevation. And there is a point where that becomes too much elevation with a left bundle branch block, and that's 5 of those basically big boxes. If you get 5 millimeters of elevation, more than 5 millimeters of elevation, that's too much, and that would meet criteria for STEMI if you see that in 2 contiguous leads. Same thing if, like here, where is it? Yeah, let me find it. It's like if you had like downward deflection, mostly upward deflection, yeah, like this one. If you had mostly upward deflection, so a positive S wave, and your ST segment was also positive, that's a STEMI if it's 1 millimeter or greater. If you have a positive deflecting S wave and a positive ST elevation with the left bundle, that's a STEMI. So that's what this is trying to show. You got that positive, this would be like lead 1, for example. You got that positive deflecting S wave, and you got ST elevation of 1 millimeter or more. That would be concerning for STEMI. Same thing, if you had like that in lead V1 or V2, V3, where you got that big, deep, QRS complex. If you also have ST depression of more than 1 millimeter, because usually it's elevated, right? If it's actually depressed, that's concerning as well for potential like a posterior component. So it's kind of confusing. I just want to let you know there are criteria to use that you can actually diagnose an MI with an underlying left bundle branch block. And every few years I'll see one and make that diagnosis. It's not common. Maybe every once 2 or 3 years I'll see that. Yeah, so here's a good example of an acute MI in the setting of a left bundle branch block. Sorry for all this writing right here, but you've got well above 5 millimeters of elevation here in contiguous leads. And you also have ST elevation with a positive S wave. So really you just need like 1 millimeter. This guy's like 5 millimeters. This is a huge elevation here. So it meets the Scarbosa criteria multiple ways on this EKG. Here's another one. So again, it's a left bundle branch block. God, that comes back really bad on the screen. But anyway, it's a left bundle branch block. And then you've got positive S wave and then ST elevation. Sorry, that comes in much clearer on my computer than it does in this up here on the monitor. Anybody want to know what anybody want to guess what I don't know why it says C1. It makes me wonder if this is like a European EKG or something. I have no idea why that says C1, but anybody want to guess what that arrow's trying to point to, what's trying to point out to you? This one as well? Yeah, I think I heard it. So it's trying to point out to a right bundle branch block is what it's trying to point out to you. So again, if we thought about that,
On the downside.
yeah, on that picture, that kind of video of that electrical signal going through the ventricles, there's a disruption in that right bundle branch. It's getting delayed for whatever reason, and it's causing this abnormal pattern on the EKG. So again, instead of a negative deflecting QRS in leads V1 and V2, now it's like a positive deflecting QRS. It's in the way that the electrodes are looking at the heart, that you're on the opposite side of the heart now, so it almost kind of flips on the EKG. Again, benign rhythm, just tells me you've got a diseased electrical system. And here's where that signal is getting delayed through that right bundle branch, and that's causing this kind of appearance on your EKG. Okay. Any questions about arrhythmias? I'm sorry, yeah, these bundle branch blocks, heart rhythm stuff we've talked about so far, and then we'll go into arrhythmias. All right, name that rhythm, has a pulse. This one's pretty easy, I think. So is it fast or slow? Slow. This person is like lightheaded, feeling like they're about to pass out, their blood pressure is low, you got this slow heart rate. What do you think? Do you think atropine would work or not work? I think it's got a good chance of working. So it looks to me, when I look at V2, that every P wave has a QRS. So we're not dealing with like a Mobitz 2, we're not dealing with a complete heart block. I think there's a good chance like a 0.5 milligram of atropine would really help this person if they're symptomatic, if they're like, having lightheadedness or really low blood pressure, stuff like that. So this would be basically symptomatic bradycardia. And again, this is one that would, I think, have a good chance of responding to some atropine. I actually had a patient almost this exact EKG 2 days ago. Came in and she actually came in as a stroke alert, but it turns out her rhythm got really slow bradycardic when we got her back from CAT scan, because we initially CAT scanned her head. We got an EKG and it's really slow bradycardic rhythm, and then there was just a little bit of elevation in 2, 3 and AVF and a little bit of depression in V1 through V3. But each QRS complex had a P wave, and her blood pressure was like 80/40. And I was like, oh, I think she's having an MI, and I think atropine would help increase her heart rate and help her blood pressure. So we gave a 0.5 milligram of atropine, and it worked great. Her heart rate came up. They got to watch them real closely because they can develop VFib, but it helped her heart rate come up from 40 to like 70. Her blood pressure came up to about 105 systolic. She started to feel a little bit better, and they got her to cath lab and found the RCA lesion and, you know, fixed her. All right, what about this one? What do you think this one is? No P waves, fast heart rate, narrow QRS, it's regular. Yeah, SVT. So everyone calls it SVT, and I call it SVT. SVT is a catch-all term for any kind of arrhythmia that originates from above the ventricles that causes a fast heart rate. So AFib is a type of SVT, atrial flutter is a type of SVT, sinus tachycardia is a type of SVT. The true name for this is AV nodal reentrant supraventricular tachycardia. Nobody says that. I'm just letting you know, SVT is like a catch-all term, but everyone calls this SVT, okay? Yeah. So I'm just letting you know. It's a catch-all term, but nobody ever uses it for that. So, yeah, there you go. AV nodal reentrant supraventricular tachycardia. You want to be real specific, that's what this is. But nobody ever says that. I think if you ever said that in the ER, I'd be like, what? So, you know, whenever I see this, my first question is this person stable or unstable? Because if they're unstable, and what I mean by that is if they're altered, if they're hypotensive, they're having really bad chest pain, really bad trouble breathing, then they need to be cardioverted, like sedate and cardioverted. And again, I don't mess around. 200 joules biphasic. Would it respond to 100 joules? Probably. Would it respond to 150? Probably. I do 200 joules right away so I don't have to mess around with increasing the voltage. Most of these people are actually stable. They're able to mentate okay. They're breathing all right. A lot of times they'll tell you, man, I just feel like my heart's racing. Maybe a little bit of shortness of breath, nothing severe. Most of them are fairly stable. This is the one that you can try a Valsalva maneuver. The one I like to use is called the modified Valsalva. It's where I take a 10 cc syringe, I pull the plunger about halfway out, and I say, okay, I want you to try to blow the plunger all the way out. Most people can't do it. I've actually seen a couple people able to do it, and I've always been amazed, but most people can't do it. But what it does is it forces them to blow as hard as they can, and that is you know, a type of Valsalva maneuver by itself. And then as they're doing that, I'll lay their head down and I'll lift their feet up, and that rushes blood to the heart. And that can sometimes cause the atria to like enlarge and break this rhythm, that rush of blood to the heart. So yeah, it's got like a 50% success rate or something like that with SVT. Other type of Valsalva maneuvers is like a cold pack to the face, bearing down real hard, which is the same idea with the syringe, like bearing down real hard, carotid massage, find the carotid artery, just kind of, don't ever push on both sides, but find the carotid artery, just kind of a carotid massage. That can also induce a vagal maneuver, or a Valsalva maneuver. So at any rate, yeah, this is SVT. I never mess around with 6 milligrams. I always give them 12 because too many times I've run into the issue where I give them 6 and absolutely nothing happens. I can't tell you how many times it's happened where I give them 6. So I give them 12 right off the bat. This slide's a little bit old. I would change it to say 12. Oh yeah, that's a good point, the very bottom. So this actually, I had a patient just yesterday that I had to give adenosine to. So I warned her before we gave it, like, listen, for about 10 to 15 seconds, you're going to feel terrible. And we gave her the adenosine. And she had a longer pause than most. I mean, it was a long pause before she kind of came back. And she was like, whoa, whoa. And then I was like, just breathe through it. Breathe. I always tell them, just breathe through it. You're going to be all right. And then she was like, man, I'm glad you warned me. That was terrible. I was like, yeah. So I always warn the people, if, you know, before I give it, hey, you're going to feel terrible for about 10 to 15 seconds. And within 20 to 30 seconds, your body has completely metabolized this medication. Like, it's gone. So it's a very, it basically poisons the AV node. It poisons the electrical system. And with PSVT, that's what you want to do. You want to poison this AV node, and it will reset the heart's electrical system. But by poisoning that AV node, you're basically stopping the heart for a short period of time. Very short period of time.
And that's really scary when you're in the back of the ambulance for yourself.
Oh, I'm sure. I'm sure it is. It's scary when I got a bunch of staff in with me, but yeah, that's what that adenosine does. It poisons this AV node for a very short period of time. All right, anybody want to take a guess? This is the same person, just to kind of to help you out. Anyone want to guess what this arrhythmia is? The arrows kind of help, but identify it. So when we look at this EKG, we got P wave before every QRS. What do you think about that PR interval? Like, to me, that's really short. There's not a lot of distance between the P wave and the QRS. Like, that's really short. And you see like that little, they call it the hockey stick, but that little upslope there, that's unique. You don't usually see that little hockey stick. I don't, it's hard for me to get it with the light. But that PR interval in the very beginning of the QRS complex, you get that hockey stick appearance. Anybody know what that's called, by the way? That hockey stick on the QRS? It's called a delta wave. So you've got a very short PR interval with a delta wave, a little hockey stick appearance. And then all of a sudden they went from this rhythm to this. Any idea what that is now? Yeah, it's a good example of Wolff-Parkinson-White. Again, atrioventricular reciprocating tachycardia. Nobody ever says that, but that's what it's called. Everyone always says Wolff-Parkinson-White. So with, I'll just say SVT. With SVT, the accessory tract involves the AV node. It's right here is where you're having it. With this, it's in a different location. It's the accessory extraelectrical tissue does not involve the AV node. And that's important because, one, it'll give you a wider QRS complex. Two, it can make it go extremely fast because you're not utilizing the AV node anymore. And the AV node's still trying to slow this down, but it has much more difficult time doing it. If you give adenosine to somebody with this rhythm, and that AV node is trying to slow this down, but it's having difficulty doing it, and then you give adenosine, you poison this AV node, and now this is able to just run untethered, like without any kind of interruption, this all of a sudden gets way worse and you go into VFib arrest. That's just what happens, what's going to happen. So that AV node is basically doing its best to try to prevent VFib arrest. And if you poison that AV node, VFib arrest. So any patient with a wide complex tachycardia that I think is SVT, I worry, could this be Wolff-Parkinson-White? I will not give adenosine to somebody with a wide QRS, SVT appearing pattern. The vast majority of these that have a wide QRS that are fast like this are people with known bundle branch blocks. And that's not dangerous. That probably is actual, reentrant tachycardia right here. But especially if I don't know for sure that they have a history of a right bundle branch or a left bundle branch, and I'm seeing a wide QRS with a very fast arrhythmia like this that's regular, man, you gotta be worried about Wolff-Parkinson-White. And I don't mess around. I don't do adenosine. I just sedate you and cardiovert you. That's what I do. I would encourage you to do the same. If you see a wide QRS very fast like this, be cautious with adenosine because you may precipitate a VFib arrest. Luckily, this isn't that common. It's not. Again, same thing. I see it maybe once every 2 or 3 years. I'll see a Wolff-Parkinson-White. Now this I'll see every once in a while, like this EKG. I'm like, hey, there's a good chance you've got this condition called Wolff-Parkinson-White. I'm just letting you know. I'm going to have you want you to see the cardiologist. They'll do a little bit more testing to kind of make sure. But the reason that's important to tell people that they may have this is because it can develop into this. It's very dangerous. So every once in a while I'll get an EKG. I'm like, really short PR interval, delta wave. I wonder if, I'm kind of worried they've got Wolff-Parkinson-White. All right, what about this one? So again, I like to look at lead 2. When it's fast like this, it could be hard to tell if there's P waves or not, but I'm not convinced. I think these are T waves we're seeing here. And then, again, when it's fast, it could be hard to tell if it's regular or irregular, but to me, this looks like the R to R interval. It looks longer, the peaks of the QRSs looks longer here than it does here. So that would be irregular, and it would be fast. I'm not convinced that there's P waves. What do you think? Yeah, I think so too. I think this is atrial fibrillation. And in my mind, atrial fibrillation gets divvied up into one of 2 categories, stable or unstable. Kind of like a lot of these arrhythmias, honestly. It's stable or unstable. And the way you identify this, like we just talked about, it's an irregular rhythm. There's no P waves. It can be fast, slow, or normal rate, depending if they're on medication. Most people, if it's a new diagnosis of AFib and they're not on any kind of rate control medication, it's going to be fast, most people. So if you're having like severe chest pain or diaphoretic or hypotensive, severe like respiratory distress, then these people are unstable. They need to be sedated and cardioverted. I do a lot of cardioversion of AFib, not from an unstable standpoint, but more of it's like stable AFib. They're on blood thinners already. I'm not worried about a clot sitting in their heart. Probably the quickest, easiest way to get them feeling better is to sedate and cardiovert them. Now, if they're stable for you guys, I don't want you guys doing that because it's a lot of conversation I have to have between a cardiologist and myself and the patient before we go down that road. If they're stable, you've got time. There's nothing really you need to do emergently with them. But unstable, sedate and cardiovert.
Dr. Schneider?
Yeah.
Do you know off the top of your head what kind of percentage of people that are diagnosed and live with atrial fib ultimately have a stroke?
Oh gosh, what is the percentage like per year? So if you have untreated AFib, oh man, I don't want to throw out a wrong stat, but I think it's like maybe 5 to 10% chance per year of having a stroke event if it's untreated, if that kind of helps answer the question. I know some of the biggest, nastiest strokes I've seen, like huge clot burdens within the brain, it was from undiagnosed AFib. Those are the ones that I see, like really large clot burdens sitting in the brain that go for clot retrieval. Yeah, the vast majority of my clot retrieval patients are probably undiagnosed AFib or AFib where they're not compliant or not on blood thinners for some other reason. Maybe they had a bad GI bleed history or frequent falls or something like that. For whatever reason, they're not on anticoagulation. But I can't remember. There is a stat out there, like if you have AFib and you don't take any kind of anticoagulants, it's a certain percentage chance per year that you've got of having a stroke, something like that. I can look that up later for you. So again, these two can be easy to confuse. You gotta be a little bit careful, like at first glance, because they both have narrow QRS complex, normally would have a narrow QRS. They both don't have P waves. They're both fast, or they can be both fast. Usually they're both fast. The way to tell the difference is basically, is it regular or is it irregular? And if it's regular, it's going to be that reentrant nodal tachycardia. If it's irregular, it's almost surely going to be AFib. Yeah. This one's a little bit different. So it's fast, it's regular, but you've got this kind of sawtooth pattern between the QRS complexes. And yeah, it's flutter. And flutter is kind of interesting because it usually happens at very set rates. 150 is the most common rate for flutter, but it can be 100, it can be 75, it can be 60. It can go between between rates, so you can be like 150, and then for a short period of time you're at 100, then back to 150, and then so it can kind of jump around. So yeah, atrial flutter. Atrial fib almost always occurs in the left atrium where you get inappropriate signals happening and it's in a very irregular fashion. And then atrial flutter usually originates in the right atrium where you get this very kind of organized abnormal electrical signal. And because it's organized, you get an organized signal through the AV node that'll cause like a regular QRS pattern. But because of with fib, it's like sending signals kind of erratically, you're not going to get that regular QRS as it propagates through the AV node. So atrial flutter, and the same thing is like with the atrial fib. It's basically, is this stable or unstable? And most people in atrial flutter are stable, but if you're hypotensive or altered, like severely altered, what I mean by that is like in and out of consciousness basically, respiratory distress, it's another indication to cardiovert these people. It doesn't seem, you're not going to hurt them with aflutter, but it's not going to help. What you'll see is you'll get that pause again, but then you'll see like just that sawtooth pattern like crazy, and then they'll kind of get back to this EKG. It just won't work. You're not going to hurt them, but it won't work. And sometimes it can be really hard to tell, is this SVT or is this atrial flutter? It's the rate that helps clue me in. If it's like exactly 150 and it looks like this, I'm like, all right, it could be SVT, but it's probably flutter. And if I'm really uncertain, then I'll just give the patient a little bit of adenosine and see what it looks like on the monitor. And if I see like that sawtooth, I'm like, okay, well, this is definitely atrial flutter. All right, what about this one? What do we think? So wide QRS, here's lead 2. Wide QRS, it's regular, it's really fast. So could this be Wolff-Parkinson White? No, I mean, I guess it could be. I would worry for like VTAC with this person, how fast it is. I mean, that's really fast. I mean, that's almost 300 beats per minute. I mean, that's really fast. What about this one? What's this one called? That's torsades. So what do we need to give this person? Magnesium. 2 grams magnesium sulfate. Almost assuredly, this person's not perfusing. Okay, this person's going to be probably pulseless and unresponsive. This person could be awake. This one on the left. So VTAC can come in stable and unstable varieties. This one, torsades, you're most likely unconscious and probably without a pulse. So like we're talking about with AFib, like we're talking about with A-flutter, like we're talking about with SVT, it's stable versus unstable. If you're unstable and you're awake, sedate and cardiovert. Obviously, if you're unconscious, don't mess with the sedation, just cardiovert them. But if they're awake, yeah, they probably will, honestly, yeah. And then amiodarone 150 milligrams over 10 minutes if they have a pulse. And you guys nailed it. If it's torsades, the treatment's magnesium 2 grams over 2 minutes. And that was that whole QT interval we were talking about. If it gets really prolonged, it can cause this torsades phenomenon to occur. And the magnesium helps to shorten that QT interval. All right. I've never tried a Valsalva maneuver, honestly, for VTAC. This is an old slide, so I must have been something I read, but I've never tried that. I've always either done amiodarone or I have to cardiovert them. I had a guy not too long ago, it's been about a month, where he was in VTAC, and his blood pressure was like 100 over 60, and he was mentating okay. And then I had a cardiac arrest come into room 21, and I had the crew for my VTAC guy get all the sedation ready, and had him put on the cardioversion pads and whatnot to cardiovert him. I had the cardiac arrest come in. I was dealing with the cardiac arrest, and then my PA, Lindsay, came in and said, hey, your VTAC guy, he's not doing too good. His blood pressure's going down to like 80 systolic, and he's starting to kind of go in and out of consciousness. I'm like, you're going to have to run that cardioversion. I'm going to need you to do this. I got to take care of this guy that's in cardiac arrest. You're going to have to sedate and cardiovert that guy. So yeah, Lindsay did a fantastic job, and he ended up doing fine. But yeah, it wasn't too long ago we had a VTAC patient that went from stable to unstable and had to be emergently cardioverted. We had given him amiodarone beforehand, but he kind of stayed in that VTAC rhythm. All right, I always joke with this slide. So this is VFib. I always joke that whoever took this EKG should be fired because you should never get an EKG with VFib. That's horrible patient care. Like, that's a person that's pulseless. You should never have a pulseless patient getting an EKG. So whoever got this, if this is a real person, I feel bad for that person because that's a real disservice. Like, that, you shouldn't be getting an EKG on VFib. So basically, you got electrical signal all throughout the ventricles, no rhyme or reason. The ventricle, it literally looks like a bundle of worms crawling around in a sack. I mean, it's not doing it. It's not pumping effectively at all, so you're not getting any kind of perfusion to the brain or to any of your organs for that matter. To see it is to shock it. So I was always told, you see this, you think shock. Like, just, these people need electricity. You need to shock them. That's what's going to save them. Now, you can give them amiodarone, we can do the chest compressions, we can do all the other things, epinephrine. That's all to try to make your shock more successful, okay? What they need is electricity. You need to shock them. If you think, oh, maybe this is torsades, give them the mag. That's fine. But what they need is electricity. So shock them, and then if it doesn't work, you're giving the medicines, you're doing the compressions. I call it priming the pump. You're priming the heart for the next shock. You're getting ready for the next shock. But electricity is what's going to save these people. So there's a couple different options. You guys know this as far as pad placement. There's the anterior apex approach, and then there's the anterior posterior. Either one's perfectly fine. I personally like this one more, but either one's perfectly fine. And then I've never done this. I want to. I never have. I've had a couple colleagues do this. For refractory VFib or pulseless VTAC, let's say you've got like the anterior posterior pads on, the way I like it, and they've gone through like 3 rounds of ACLS, tried shocking them 3 times, we're giving them the drugs, and they just staying in VFib or pulseless VTAC. I can't get them out of it. Well, there is a procedure called a double sequential defibrillation where you put another set of pads in the opposite location. So if this is where our pads were, you put another set of pads in this orientation. And you basically use both monitors to cardiovert within like 2 seconds of each other. So you hit them, and then you hit them, with the other monitor. And the idea is you're getting a larger area of the heart hit with electricity, and hopefully can snap them out of this, VFib or pulseless VTAC. So I've had a couple of my colleagues do this in the ER. I've always, I guess it's a good thing, been successful cardioverting them out of the VTAC. Yep. Schuler, Guffey, I think both of those guys have done it. Yeah. Schuler, I think Schuler's done it
I
too.
was denied with this by people. They said that it would void the warranty on their.
Yeah, so I brought that up to.
So they said no.
I brought that up to Nettie because years ago when I was a medical director, I was wanting to start doing this because there's pretty good data out there that it probably works. And I was told the same thing. So Nettie looked into it and she goes, I don't think we've got a problem. I think we're fine with this.
We're doing CPR through shocks over in Europe.
Yeah,
So I don't think
yeah, exactly. So I got the green light from Nettie, and that's good enough for me. So we're good. We got that put in. But I remember years ago wanting to do this and was told the exact same thing about something about the warranty. All right. So name that rhythm. We've got no pulse, but look like we have organized electrical activity. Yeah, this is PEA. So that's that one. It's got those reversible causes, those 10 reversible causes. It's going to be one of these, and really, the quicker you can identify and treat which one of these it is, the more likely they're going to survive. And to be honest, I kind of take a shotgun approach and treat almost like all of them all at the same time. So hypoxia, obviously any kind of cardiac arrest, we're giving them 100% oxygen. Whether it's bag valve mask or King airway, or if you intubate them, they're getting 100% oxygen. So if it's from hypoxia, we treat that every time with any kind of cardiac arrest. Hypovolemia, again, almost every patient that we've got in cardiac arrest, they're getting a liter of fluid. Most likely, they're getting some fluids put on. And if it looks like it's from blood loss, then, again, fluids, and then trying to get blood up from the blood bank. And eventually, you guys, the chase truck is going to have a couple units of blood on it. So that's coming down the pike. It's going to happen. Really, the only holdup is we have to get an agreement with the lab so we can do blood swapping. But once we get that agreement done, it'll be there. Acidosis, that's the one why, in the ER when we have a PEA cardiac arrest, we are very quick to give bicarb because it doesn't take very long in a low flow or no flow state, so the heart's not beating or beating very inefficiently, to become acidotic. And yeah, exactly. And the drugs don't work. And when your pH gets below 7.2, your myocardium really starts not functioning as well. It doesn't take long for your pH to get to that point if your heart's not beating well. Yeah. So it was funny when I asked because the controversy with bicarb is that it's not in like the American Heart Association algorithm of how to treat it. But man, I think there's some decent evidence that it probably should be. And when I asked, every one of my colleagues had the same response. Well, yeah, I give bicarb. And I'll say, why? They'll say, because it works. Yeah, okay. So I'm a fan of giving it, especially in PEA arrest. But I would never make it mandatory for you guys because it's not like in the American Heart Association standard guidelines for it. So it's in your protocols to consider to use. I use it. Most of my colleagues use it. but I would, like I said, I would never mandate it since it's not specifically listed in the American Heart Association as far as what should be done.
You
But
do that, when you give your bicarb, do you do it by weight based, or you just give it?
so technically you're supposed to, I'll tell you what you're supposed to do and I'll tell you what actually happens. So technically you're supposed to do it weight based. 1 mil equivalent per kilogram, I believe, is the dosage. Yeah.
You're actually underdosing people.
Yeah. Here's what actually happens in the ER, for better or worse. We probably could do better about this, but we will give an amp of bicarb. We'll give the epi first, and then we'll give an amp of bicarb. We'll go through a couple minutes of ACLS. If it looks like we got a pulse, great. If we don't, they get another amp of bicarb. And then after 2, usually we stop. Some people get really aggressive and give a 3rd and a 4th and a 5th, but usually after 2. If it's not fixed after 2, it becomes much less likely you're going to get them back with bicarb. Yeah. So that will typically get you to that 1 milligram per kilogram, if not more so, if you do it that way. So I'm not saying that's the right way to do it. I'm just saying that's the way most of us do it in the emergency department setting. So, but yeah, acidosis is one of those conditions that can, actually a common condition in my opinion, that will cause PEA. And then hyperkalemia. Yeah, the treatment for that is calcium to stabilize the heart. So basically when your potassium gets really high, it poisons the electrical system, and it'll cause usually your heart to get very slow, and then your QRS to widen out, and eventually if it gets really bad, you'll see it's just this big sine wave, and that's a non-perfusing rhythm. But if I have a patient that's like, hey, it's a dialysis patient that's in PEA, or for whatever reason they've got known severe kidney dysfunction, I have a low threshold to give them calcium. Now you have to be a little careful with calcium and bicarb. You got to flush between the two, because you give calcium bicarb back to back, you can actually,
Like each other.
yeah, you can precipitate. You can form like a solid. You can precipitate the calcium. So you got to flush between the two.
Or just have flowing fluids, correct?
Yeah, that works too. That works perfectly fine too. Hypothermia, pretty obvious. You warm the patient. You're not dead until you're warm and dead. And then toxins, many of which the antidote is bicarb. So, aspirin toxicity, tricyclic antidepressant toxicity. You'll get this widening of the QRS, and bicarb is one of the treatments for that. Tension pneumothorax, every patient with PEA, I want to make sure I'm hearing bilateral breath sounds. And if I'm worried that, man, I'm pretty sure I'm not hearing breath sounds on one side, I'm needle decompressing that person and seeing if I hear a big hiss of air. Again,
Dr. Schneider,
yeah.
hypothermic arrest, there is probably no possibility we've got somebody in the hospital that can run a heart-lung machine we could hook
The
up.
ECMO, yeah. So,
They do it in big centers.
they do. Not that I know of, not in the ER setting. If they survive and get to the ICU, maybe, but not that I know of. Even then, I think most of our ECMO patients get transferred to Methodist. I'll ask my ICU folks my next shift, but I was just curious. I don't remember any of them ever being on ECMO. I think they get transferred to get put on ECMO.
Right.
Yeah. Yeah, tension with, like I said, I always listen. If I'm like, man, I don't hear breath sounds here, and my initial interventions aren't working, I have a very low threshold to just needle decompress and see if it will save their life. Because again, if you don't reverse what's causing the PEA, they're not going to make it. Tamponade, it's rare. It's more common. That's where the bunch of fluid builds up around the heart, compresses the heart to where it can't function properly. The treatment is to relieve the pressure by taking the fluid off. This is pretty rare. It's more common in bad trauma, where you'll get some bleeding into the sac around the heart. You can also see it in bad cancer patients. They'll develop fluid around the heart, or renal failure patients can sometimes develop this too. And then this is one where we put the ultrasound probe on, take a look at the heart. And every PEA patient, I'm putting the ultrasound probe on, looking at the heart. One, to see if I've got any kind of squeeze at all, and then two, to see if there's a bunch of fluid around the heart. Yeah, big pulmonary embolism, acute coronary syndrome. And then trauma, usually it's from blood loss. But again, trauma can lead to your tension pneumothorax, trauma can lead to hypovolemia, trauma can lead to tamponade, it can lead to some of these other things. Heck, even bad burns can lead to hyperkalemia. So, yeah. The rhythm of death. So that's asystole. So I always, whenever I see somebody asystole, for better or worse, my thought is the only real chance this person has of survival is if for some reason the equipment's not hooked up correctly. Because it's like a 99.99% chance you're not going to survive this. So whenever you guys call and will say, hey, I've got this patient, we've been coding them for however many minutes, 15, 20 minutes, I'll say, hey, what's your most recent rhythm? And then if the response is asystole, my immediate next response is, are you sure all the equipment's hooked up correctly? And it's not to be mean or disrespectful. That's really the only chance they've got for survival, is if somehow your equipment's not hooked up correctly. Because otherwise they're not going to make it. So if you ever had that conversation with me, that's why. It's because that's their only chance they're going to make it, is if you've been coding it for 15, 20 minutes and they're in asystole, the only chance is maybe you got something not hooked up correctly. And if they say, yes, we've checked, everything's hooked up correctly, then we call the code and say, we're done. So, yeah. So if there's a worry, hey, could this be very fine VFib? I think I see a little bit of bumps. By all means, go ahead and shock it. It's fine. You're not going to hurt anything.
That's when I woke up when I put the pads on me.
Yeah. But yeah, the treatment, epinephrine, you'll see some of my colleagues give bicarb for this one too. That's a little bit more debatable, but epinephrine is the mainstay drug here. Good ACLS measures, and then, like I said, I have yet to see somebody survive asystole. Now, I've seen them get to the ICU and then end up being withdrawn from life support and passing. I've never seen somebody have a meaningful recovery from asystole. Sounds like it happens, but I've yet to see it. I've yet to witness it myself. The times where I think it could potentially see it would be in the winter, if somebody's like really hypothermic and it looks like they're in asystole, but honestly, they're probably in a very slow escape. It's probably actually not asystole. But at any rate, that's the only time I could potentially see it. So even with perfect ACLS measures, very, very, very high probability you're not going to survive asystole. All right, so when it hits the fan, you're like, oh my gosh, my mind's blank. These are the things I think of, like just ingrained, seared into my mind. VFib, shock. Asystole, are my leads correct? SVT, stable, unstable. VTAC, stable, unstable. PEA, what are my reversible causes? Like I said, if you can't remember anything else, this is like the bare bones stuff to think about when you see these different types of rhythms. So again, VFib, to see it is to shock it. Asystole, probably dead unless there's something going on with the leads. Very unlikely they're going to survive it. SVT, most of them are stable, but the unstable ones where you got low blood pressure or they're in and out of consciousness, respiratory distress, those people need to be shocked. Otherwise, you can try some adenosine. Make sure it's not a YQRS because that makes me nervous about Wolff Parkinson White. VTAC, if it's stable, you can give them amiodarone, 150 milligrams over 10 minutes. If it's unstable, obviously they need to be cardioverted. If they're awake, sedate them first, please. PEA arrest, you got to think about those reversible causes. They're going to not make it. They're going to die unless you can quickly reverse whatever's causing them to be PEA. With kids, the most common cause of PEA arrest, by far, way above all the others, is hypoxia with kids. By far and away, the most common cause of PEA arrest. All right. That's all I got for you guys. Any questions?
Now's your chance.
Thanks a lot, Chris.
No problem, of course. Yep, no problem.
Hope you have a wonderful day in the ER.
Yeah, I get there at 2.
Can I get a couple signatures?
Sure, of
for,
course.
Captain Spencer?
Yeah.